Good evening, everyone. We'll wait for a few more minutes to let others join and then we can start today's session. I guess we can start. Let me share my screen. I hope you people are able to see the PowerPoint. Okay, so good evening, everyone, and welcome back to week 7 of PMRF TS sessions for NPTEL online course Drug Delivery Principles in Engineering. So, we are halfway through the course, and let's start by discussing some of the key points that were discussed in week 7 lectures. So, until now, we have looked quite extensively towards drug delivery and some basic concepts that are involved in drug delivery, the pharmacokinetics, the bioavailability of the drug, and certain parameters of the drug itself, the TD50, the LD50, or the ED50 values, and so on and so forth. And then we started looking at the actual drug delivery systems. For example, we learned about hydrogels and how their advantages, and we also talked about reservoir systems, we talked about matrix systems, we talked extensively about their applications as their advantages as well as disadvantages, and we learned an important fact that no matter you have to choose from a number of different drug delivery systems, and the choice always depends on what application you are looking for, what is the disease or the disorder that you're trying to treat. And since we have multiple different options, we have to look for which would be the best suitable drug delivery system for my particular application. And then after looking at these different systems, we then moved on towards tissue engineering. So in tissue engineering, we saw that there are so what basically tissue engineering is, it is where you integrate your engineering principles, your biomaterials, and the engineering principles and biomaterials to mimic a tissue in vitro in lab, so that you can use that artificial tissue that you have prepared using tissue engineering principles and replace it into a patient's body wherein you have a damaged tissue. And we saw different ways of doing this, and we also learned about how drug delivery helps in tissue engineering, wherein let's say you have to integrate certain growth factors. So how do you implement those in the organ or in the tissue that you have artificially formed. So not only growth factors, there's a possibility that you might have to deliver antibiotics. So we saw how to do that as well. So we have different methods, right? You can cross link, you can link your or attach your growth factors or antibiotics to the biomaterials by using its natural capacity to adhere to these biomaterials, or you can use certain molecules such as heparin, which is present in the extracellular matrix in a human patient, and so on and so forth. So we saw these different methods, and then the course moved on towards implant associated infections. This is what we learned in the last lecture as well. So implant associated infections are nothing but whenever you put a biomaterial or an implant in a patient's body, because the cells in the patients, the human cells as well as the bacteria, they have affinity towards these surfaces, and they start attaching themselves on these surfaces of biomaterials or implants, and they then lead to device failure, because there's a lot of biofouling that happens on these implants. And also bacteria have this ability to form biofilms on these implants, so that is a concern, because then these biofilms give the ability of rejecting they don't let the immune system of the patient in eradicating the bacteria, so they actually make the bacteria more virulent, and in that case the device then fails. So the only option that we have is to remove the biomaterial or to remove the implant from the patient's body to avoid getting these infections. So we also saw how there are certain ways to reduce these implant associated infections. We saw that by making the surface more hydrophilic or by making the surface more smooth, we can avoid some of these infections, or there's a way to put antibiotic layer or antibiotic, we can attach antibiotics to these implants or biomaterials, and then that will help in reducing these infections. So this is what we saw in the last few lectures. Hold on. Yeah, so then the course for week 7 lectures, we then started looking at some of the route specific delivery. So this again, as I was, anything that leads to drug delivery always depends upon application. So there are different routes through which we can deliver drugs in a human patient. So as I said, that always depends on application, meaning, let's say I'm trying to treat tuberculosis, which majorly affects the lungs of a person. So in that case, do I want my drugs to be given orally, or do I want my drugs to be given intranasally, wherein I know that if I give something intranasally, most of the drug will end up in the lungs. And so do I have methods to do that? Are my drugs feasible by giving when they're given by intranasal, or will they get damaged or so? So this also depends on, as I said, application and also the physicochemical properties of the drug. Let's say I have a very nice drug, and I tried giving it intranasally, but then I found out that the way the drugs have to pass through a mucus layer when they're given intranasally, and my drug doesn't really perform well in the mucus layer. The mucus is able to metabolize the drug. In that case, most of my drug is getting lost. So now I can't use the intranasal route. I have to try out a different route. So all of this depends on the application and the physicochemical properties of the drug, and also on the dose. So not so all the different routes that we have, not all of them don't perform in the same way. So there is a possibility that, let's say, I can give a very high amount of dose orally, but I cannot give that via injections. So all of this depends on what application you have, and then you decide which is the optimum route of delivery that you want to choose. So then we started looking into specific routes of delivery. The first that we discussed is oral route. So this, you guys must be really familiar with oral route, because we all have taken tablets, we all have taken syrups or capsules at some point of our life. And so these are different ways in which a drug can be formulated to give through oral route. So most people prefer oral route because it's very, very patient compliant. You don't have to do anything. You just take a pill, you take a medicine, and that's it. So there's no injection involved, there is no pain involved. So this is non-invasive. It doesn't harm you in any way. So that's why most people prefer oral route. So but as I said, there will always be certain advantages and certain disadvantages associated with these different routes of drug delivery. So the disadvantages associated with oral route are, first of all, first pass metabolism. If you people remember it from some of our previous sessions, what first pass metabolism is. So whenever you give drugs orally, so this happens specifically in the case of oral administration. Whenever you give drugs orally, most of it gets metabolized into the liver even before it reaches the site of action. So then this leads to we lose a lot of drug in this oral route because of this first pass metabolism. So that is one disadvantage. As a result, you have to administer a lot more dose than is actually required, because we are losing a lot of drug. And then there is also degradation in the GI tract, as I said. So our gastrointestinal tract is lined with mucus. There are enzymes which start degrading the drug, because the drug is a foreign material for the body. So the body thinks that this is something foreign and I have to start degrading this. Or it could be that so the pH varies as and when we go lower to the digestive tract, right? So maybe the drug performs really well at a certain pH, but once it enters the stomach, wherein the pH is very very low, maybe the drug gets disintegrated. It is not able to perform well. So that is another disadvantage. And the course also talks extensively about formulations, how drugs are formulated. Do we require any excipients? Excipients are nothing but these are certain components in the formulation which help the drug. Let's say it helps in making a tablet out of the drug. Or there could be binders which helps in binding these drugs together in a tablet form or in a capsule form. So oral route has been discussed very extensively in the lectures. You people can go through it. So for now I'm just giving you a brief introduction of this so that it can help us solve some of the questions in the upcoming assignment. So that's about oral route. And then so with oral route also we can make control release dosage forms. So these could be something known as an osmotic tablet. So this also we had discussed in the previous lectures. So what is an osmotic tablet? It is nothing but a tablet which has a particular polymer inside it. And what happens is, when you ingest this tablet, as and when water rushes through into this polymer, the polymer starts swelling. So we use certain swelling control polymers to make these osmotic tablets. So because of osmosis, because the water enters the polymer starts swelling inside the tablet, and then our drug is also present in that polymer. As and when the polymer swells, it starts pushing the drug out of the tablet. So there's a small hole, small orifice on the top of this osmotic tablet, and it will start pushing the drug outside. So in that way we have certain amount of control of how much drug gets released from this particular tablet. Then we have something known as enteric coatings. So what are enteric coatings? Let's say we want our drug to work only in the intestine, right? So, and as I was saying, whenever the drug taken through an oral route, whenever it passes through the stomach, it passes through a very very low pH condition. So there is a possibility that your drug might get disintegrated at that pH. So we don't want that. We want our drug to specifically work only in the intestines. Are you people? Okay. Right, so we want our drug to work only in the intestine. So what we do is we coat our drug with a polymer, and we choose a polymer in such a way that it will have a lot of carboxylic acid groups. So this is your COOH group. So if your drug has, if the polymer has a lot of carboxylic acid groups, what would happen is, whenever it enters a low pH area, a low pH environment, there will already be a lot of H plus surrounding this particular tablet whenever it passes through a low pH area. So what would happen is, your COOH groups will all be protonated. They will be in COOH form. So as a result, the polymer will not be soluble. But what happens once your drug enters from your stomach area to your intestine area, where the pH is very high, the pH is around 8 or 9. In that case, the COOH groups will start deprotonating. They will lose their H plus ion. So now it carries a negative charge, which is much more soluble than your previous COOH form. So your CO minus is more soluble compared to your COOH form. So in that case, the polymer will then start dissolving, and then it will release the drug in that process. So what have we done using these enteric coatings is, we have protected the drug first of all from the low pH conditions in the stomach, and we have done a targeted drug delivery only to the intestines. So that's one use of enteric coatings. So this is one way to have controlled release dosage forms. Another is bioadhesives. As I was saying, so when you take a drug through oral route, there's a mucus lining our GI tract, the gastrointestinal tract. So we want a drug to stay in that tract for a longer time. In that case, what I'll do, I'll just cover my drug with a lot of polymer chains. So these polymers, since they are like a brush, they have these chains, long chains. So they will then interact with the mucus, and they will just bind to the mucus at one particular area, like an adhesive, as if I've glued the drug to that particular area. And in that process, then the passing of the drug will slow down. So I'll get a much more controlled release from these dosage forms. So these are some examples of it. So that's about oral route. Then the next route that is discussed is subcutaneous route. Okay. You people are able to hear me, right? Can somebody just confirm this? I am a little skeptical. So you can write it in the chat box if I hope I'm audible to you people. Right. So about subcutaneous route. So what is subcutaneous route? So so we are made up of this layer, right? You have your skin layer first of all, then you have a subcutaneous layer, then you have your muscle layer, the intramuscular layer. So in subcutaneous route, what we do is we take an injection. So all of these are parenteral, meaning you have to inject the drug in the patient's body. So you take an injection, you take a syringe, and you carefully put the syringe only in the subcutaneous route. We'll discuss this further detail in one of the questions of the assignment. So you have this under the skin, you have this subcutaneous layer, and that's where you inject. You put your syringe, you put your injection there, and then you slowly release the drug there. So your drug is now released in the subcutaneous layer. That's why this is known as a subcutaneous route. So one advantage, the most important advantage of subcutaneous route is it bypasses the first pass metabolism. So if you remember, first pass metabolism is a problem only when drugs are given orally. So once you inject something in the subcutaneous route, it will bypass the first pass metabolism, because your drug is not now reaching in your stomach from where it gets carried to the liver. So that is not happening. So we are bypassing first pass metabolism. In that case, you don't have to give a lot of amount of drug, because you're not losing that much amount of drug. So that's one advantage of subcutaneous route. The disadvantages for this route are invasive. Invasive meaning it will cause some amount of pain, because it's an injection and you're putting it into the skin of a person. So that is going to be a little painful. So people don't usually prefer subcutaneous route. And another disadvantage is it can only take 2 ml of the solution. So you have to make your formulation really concentrated if you want to give in a lot of amount of drug. Then so similar to subcutaneous, so this is about subcutaneous route. Similar to this, you have intramuscular route. So as I said, you have a dermal layer, you have a skin layer, below that you have subcutaneous layer, and below that you have your muscle layer. So yeah, so in this intramuscular route, so then you take, instead of putting it in the subcutaneous route, you put your injection into one layer below in the muscles. So this is your intramuscular injection. So advantage of this, definitely it again bypasses the first pass metabolism. Similar to subcutaneous, it is invasive. It is actually very painful. Intramuscular injections are painful, and quite a bit of training is needed, because you might, so if an untrained person starts taking it, there's a possibility that they might miss the intramuscular layer. They might put it in the subcutaneous, or they might put it in the intravenous route. So so that's why training is required, and patients themselves cannot administer these injections. So they have to go to a clinic, or they have to go to a trained person to administer these injections. So these are some of the disadvantages of subcutaneous and intramuscular route. And then the last route that is discussed in these lectures is transdermal route. So what is transdermal route? As I said, skin layer, subcutaneous, intramuscular. So instead of putting injections in your subcutaneous or intramuscular layer, you just put the drug in the first layer, the skin layer, the transdermal layer. So these are easily administered. For example, you must have seen people using nicotine patches. They just put a patch here, or you must have seen people using pain patches, people who play. If they have an injury or something, they'll just put a patch on it, and the drug is already loaded in that patch. And once it has these small needle like structures that will only pierce your skin layer. They are not very painful, but the drug that is present in these patches then gets administered in the transdermal route, and below this route there's a layer of blood vessels, right? So your drug will be in the blood, and it will then circulate throughout the body. So that's why so this can be used for distribution of the drug throughout the body, although that will be very less. Most importantly, transdermal route is used for local effect. So I have pain in my hand, I'll just put a patch over wherever the pain is. So it has local effect, it is easily administered, patients can themselves administer through this transdermal route. Some of the disadvantages of this route, it requires only low dose or low molecular weight of drugs to be administered. So if you want to give a very high dose, transdermal route is not optimal for that. Also, if your drugs are of a very high molecular weight, this route is not suitable. And there could be immunogenic response because your skin layer is trained as the first line of defense for any foreign material. So there'll be a lot of there'll be a lot of immunogenic cells in your skin, and they might think that there is some injury to the skin, or they might think that this drug is foreign, so they can launch an immunogenic response. And so what happens in a transdermal route is, because your skin is not just a skin layer, right? There'll be a lot of dead cells also on the top of the skin, so they make delivery through transdermal route a little bit difficult. So to enhance that, we have different chemical and physical methods which we'll be discussing in the upcoming slides. And as I was saying, so microneedles are specifically designed to deliver drugs through transdermal route. So you can read the details about microneedles in the lectures. So with a brief introduction of some of the points covered in these lectures, we can then move on towards the questions for today's assignment. Does anybody have anything else to discuss before I move on towards the questions? If there are any doubts, then I'll just take a pause, and if there are no doubts, then we can move on towards the assignment questions. Okay, I'll then move on towards the questions. Let's look at the first question. So we have to rank the following injection routes in order of the shallowest to the deepest needle penetration. So we have just been talking about how the layers are arranged, the skin layer, or your subcutaneous or your muscular layer. So we have to rank the injection route from the shallowest to the deepest needle penetration. So take your time in reading through the options, and if anybody knows the answer, please let me know. I'll pause for a few minutes, and then we'll discuss the answer. So you people can unmute yourself and let me know the answer, or you can write in the chat box. People who have joined a little late might have missed the initial discussion, but we are just starting with the assignment question, so you can also participate in this. I hope you can see the question displayed on the screen. Just go through the question and options once, and let me know if anybody has the answer. Okay, no responses. Okay, I think somebody is. Okay, somebody is saying intradermal, subcutaneous, and muscular. Right, you're perfectly correct. That's the correct order of the layers, the way the layers are arranged. We have been talking about this in the introductory slide, right? So, sorry. So this is how the layers are arranged. You first have a skin layer, the epidermis. Then you have a layer below it, dermis. This is where your blood vessels are located. Below that you have the subcutaneous tissue, and below that you have your muscle. So these are the angles of how you should be injecting a particular syringe in whichever layer you are choosing. So if you look at subcutaneous and intramuscular, the reason patients cannot self administer these injections is and the reason you need training is because so it's easier for an untrained person to just randomly go into the dermis layer, or they might inject themselves in the intravenous layer. So that's why proper training is required of first of all which angle to choose, so that you go specifically in the subcutaneous or specifically in the muscular layer. So this is the correct sequence of the way these layers are arranged. You first have your intradermal layer, then you have your subcutaneous layer, and then you have your muscular layer. Is this clear? If there are any doubts with this explanation, please let me know. Otherwise, we'll move on towards the next question. Thank you for answering. Okay, I guess no doubts with this. Okay, let's look at the next question. Next is, what are the advantages of drug administration through oral route? And we have to choose two options from the following list. So take your time in reading through the question and let me know the answer. Okay, somebody's answering patient compliant and non-invasive. Those are the last two options. Okay, thank you for responding. Anybody else has another answer or any other opinion? I guess there are no more. Okay, last two options. Okay, two people have answered. You both of you are correct. The correct answer is the advantages of oral route are they are patient compliant and non-invasive. So just going through this slide. So advantages are, as I said, it's convenient for patients to take medicines on their own. It is not invasive. That's why it has a higher rate of compliance. And another advantage is this specific route of drug delivery has been studied very extensively. So you have very well established processes of manufacturing tablets. You can formulate the drug in the form of a tablet or a capsule or a syrup as well, and all of these have their own advantages. And as we discussed in the introductory slide, we can have controlled release dosage forms also through oral route. And some of the disadvantages are, first of all, your patients have to be conscious while taking the dose, because unconscious patients, they won't be able to ingest the drug through oral route. So it has low solubility, low permeability. So if you have a very hydrophobic drug, there are chances that most of this drug would be lost. It won't be absorbed into the bloodstream, because whenever you're taking drugs orally, let's say you are targeting some other place. As I said, let's say I'm trying to treat tuberculosis with my drug treatment, and so the tuberculosis bacteria would be majorly in the lungs. And if I have taken my drug through oral route, it has to somehow reach the lungs, right, to have its effect against the bacteria. So if I have a very hydrophobic drug, so it won't get absorbed through the cells into the blood. So as a result, most of my drug would be lost, and I have to give in a lot of amount of dose. And there's always a upper limit on how much amount of drug you can give to a human patient, because they can quickly start becoming toxic at very high concentration. So there's this limitation of this oral route. Then, as we discussed, it's possible that the drug gets degraded by the enzymes that are present in the GI tract, or there's a lot of gut microbiota that we have, the microbes that are living in this gut, they can start degrading this particular drug. And then first pass metabolism, of course, is a disadvantage. Most of the drug gets metabolized in the liver even before it reaches the site of action. There could be food interactions, because that's why you must have seen that doctors sometimes prescribe medicines to be taken after lunch or before having food at all, because there so we have to extensively study a particular drug to see if there would be food interactions. Sometimes there's a possibility of having drug interactions. Let's say you are already taking a drug and you get some other disease, and now you have to take drugs for the other disease as well. So there has to be studies done to see whether these two drugs will interact with each other or not, and how they're interacting. What if one drug is not letting the effect of the other drug to happen? So in that case, there'll be drug interactions. So we have to take care of that also whenever we are trying to deliver drugs through oral route. And as I said, there is irregular absorption. We don't know how much amount will be getting absorbed through as and when the drug passes through the GI tract. So oral route, actually, though it is the most patient compliant route, it has bunch of disadvantages. Any doubt with this explanation? Is the question clear? Advantages of drug administration through oral route: first of all, patient compliant, and it's non-invasive. Is this clear? If there are any doubts with this explanation, do let me know, or else we'll move towards
No,
the next
ma'am,
question.
you just gone through.
Sorry, somebody trying to say something? Okay, I'll move on towards the next question then. Next is, which of the following route is susceptible to first pass effect? We have been very extensively discussing this, so should be easier to answer. Let me know if you people have the answer. Okay, thank you. There are no doubts. Yeah, we have moved on towards the next question. Okay, any volunteers for this question? Which of the following route is susceptible to first pass effect? Okay, somebody is saying oral route, option 2. Thank you for answering. Anybody else would like to give it a try? Nobody? Okay. You're correct. Whoever is answering in the chat box. First pass effect happens only when things are given orally. So we have already looked at it, right? So the first pass effect is nothing but the hepatic metabolism of a pharmacological agent. This nothing but whenever a drug is taken through oral route, so it gets absorbed in the gut first of all, in your stomach, and then there is this portal vein that carries things from your stomach to the liver to for metabolization, and that's how you lose a lot of amount of drug. So the greater the first pass effect, less of the agent will reach systemic circulation. So we want our drug to reach systemic circulation, meaning the blood circulation, so that it distributes all over the body and actually reaches the site at which we actually want it. So this is applicable only when the drug is administered orally. So the rest of the options here, sublingual, transdermal, rectal, inhalation, intravenous, intraarticular and intramuscular, they actually bypass the first pass effect. That is why they are advantageous in that sense, and most of the drug gets lost through this effect whenever the drugs are given orally. So correct answer is option 2. I hope this is clear. Right. So we'll move on towards the next question then. Next is, consider that you want to deliver drugs to the eye. Which of the following methods would work best? So take your time in reading through the options and let me know the answer. Okay, somebody is saying intraocular. Thank you for answering. Anybody else? So let's look at the answer. You're perfectly correct. It's intraocular. So intraocular is nothing but when you give things directly to the eye. So IV is nothing but intravenous, wherein you're trying to put your drug in the bloodstream. Intraarticular is nothing but you're trying to inject something in the articular space, which is in the kneecap. So that's not. So both of these ways are not going to get much of the drug to your eye. Subdermal, as we said, it's intradermal, below your in the skin layer. Intraocular, of course, directly to the eye. Intrarectal and intradermal, all of these, the rest of the routes won't deliver the drugs to the eye. So the correct answer is intraocular. I hope that's making sense. Alright, let's look at the next question then. Next is, which of the following are disadvantages of subcutaneous mode of delivery? Again, we have to choose two correct options. So we just discussed about subcutaneous route in the introductory slide as well. So read through the options and please let me know the answer. Anyone would like to volunteer for this? Okay, 3 and 4, that is small volumes of injection and causes irritation to the site of injection. Okay, anybody else? Thank you for answering. Alright, let's look at the answers. You're perfectly correct. Correct answer is small volumes of injection and causes irritation to the site of injection are the disadvantages of subcutaneous mode of delivery. So the advantages include patient self-administration. This is a little bit easier than intramuscular to put an injection for a patient to in that subcutaneous layer, and it allows complete absorption and it bypasses the first pass metabolism effect. These are the advantages. On the other hand, it's invasive. There are possibilities of having irritation or inflammation because you're actually trying to inject something in the subcutaneous layer. So the sorry right so the macrophages or the immune cells present in this particular layer, they are going to think that some injury is happening and they'll start flooding that area, which leads to inflammation. And can you please mute your mic? Yeah, and the maximum dose that can be given is only 2 ml because there's not really much space in the subcutaneous layer, so very low volume gets injected through this route of delivery. So the disadvantages of this mode are small volumes of injection and it could cause irritation to the site of injection. Is this clear? Okay, let's move on towards the next question then. Next is, which of the following statements are disadvantages of intramuscular mode of delivery? Again, pretty similar to the previous question. So we have to again choose two correct options. Again, it's about disadvantages of intramuscular route. So should be fairly easy to answer. Please let me know if you people are ready with it. Last two options, okay, invasive and irritation, perfectly correct. We just discussed about this. So advantages for intramuscular, uh, th- they can administer the drug himself is not actually an advantage, I would say. But sure, if the patient has been trained to take intramuscular injections, then yes, larger volume can be administered compared to subcutaneous, and again it bypasses the first pass metabolism. Disadvantages include invasive because there'll be some amount of damage at the site of injection. It leads to irritation and inflammation, and again it requires some training. So pretty fair. If there are no doubts here, I'll move on towards the next question then. Next is, which of these methods cannot be used for enhancement of permeation through the skin? So we were talking about this initially, wherein your skin is going to have a lot of dead cells, and it has a lot of lipids integrated in between these dead cells. So it makes a little bit difficult to deliver drugs through intradermal route. But there are ways of enhancing this permeation of the drug through the skin. So there are various different ways. So which of these options is not actually a way to enhance permeation? So if you people know the answer, do let me know. If not, we'll discuss. Okay, somebody is saying ultrasound. Anybody else? Thanks for answering. We'll look at the answer in a moment. Okay, let's look at the answer. The correct answer is actually physical rubbing because ultrasound is used to enhance permeation. So we'll just go through this particular slide. So as I said, your skin has this mortar and pestle kind of, sorry, not mortar and pestle, it has a brick layer kind of structure wherein you have your dead cells. It also has a lot of lipids which act as glue to hold these dead cells together. So whenever you're putting something, administering a drug through this transdermal route, there's a lot of barrier that the drug has to cross to enter into the bloodstream. So there are ways of enhancing this. The first is chemical enhancers, wherein you have various different compounds that actually increase the permeability by destabilizing this lipid mortar layer. So some of these include hydration. You just give it water, or you put DMSO. So DMSO, dimethyl sulfoxide, is a chemical which is capable of dissolving a lot or solubilizing a lot of different lipids. There are other molecules such as glycols, oleic acids, surfactants, or even ethanol. And the important point to note here about chemical enhancers is they should be pharmaceutically inert. They shouldn't have their own effect. of course they should be non-toxic and non-allergenic, because otherwise you'll there'll be a lot of irritation at the site where you're putting these chemical enhancers. So what will doctors do? They'll just put some layer of, let's say, ethanol or DMSO on the skin, and then later on they'll just administer the drugs through the transdermal route. So this will help in destabilizing that lipid layer and the dead cell layer. That is one way. Another way is to make prodrugs out of your drug. So because there is this lipid layer, you want, let's say you have a drug which is very very hydrophilic, so it will be difficult for the hydrophilic drug to pass through this lipophilic layer. So what you can do, you can modify the drug to make it more hydrophobic. You can attach carbon chains to it that will make it more hydrophobic. This drug would then be easily transferred through this lipid layer. That's another way. Then there is bombardment, where you use high pressure shooting of the particles into the epidermis. It could be done with a gene gun system or a powder jet system. Then there is something known as ionotophoresis, wherein you use electrical current for long duration, or you use a high voltage electrical disruption for a short duration. So ionotophoresis and electroporation. Ultrasound is nothing but using sound waves. So you give sound waves to the dead layer of skin, so it creates this cavitation forces which then destabilizes the lipid layer. That is another way. Or you can use photomechanical energy to disrupt the dead layer using some lasers. So these are some of the methods to enhance permeation of your drug through the transdermal route. So out of all the options listed here, you don't use physical rubbing because that's not going to help much. You just physical rubbing is nothing but you just rub the area and then you put your drug there, so that is not going to help destabilize the lipid layer. Is this clear? So that's the only option that doesn't fit into ways of enhancing permeation. So the question is, which of these methods cannot be used for enhancement of permeation through the skin? The correct answer is physical rubbing. Is this clear? Okay, no doubts here. Then let's move on towards the next question. Next is, the major problem of transdermal drug delivery route is. Again, we have to choose two correct options. We discussed about this briefly in the introductory slide. So go through the options and let me know if you have the answer. Any volunteers for this question? Okay, somebody saying second option, small doses administration is only possible. Okay, thank you for answering, but we have to choose two options. So if you have the other option ready, please let me know. Others can also give it a try. Okay, let's look at the answer. One of your options is correct. Whoever is answering, only small dose administration is possible. And the other disadvantage is or drawback of transdermal route is drugs with molecular weight more than 1000 Dalton cannot be given. So these are the advantages. First of all, it has a local effect and it's easier to administer for the patients. Disadvantages include there's low absorption for some drugs. As I was saying, if you have a hydrophilic drug, there's this lipophilic lipid layer which is hydrophobic in nature, so that will not let most of your hydrophilic drug to be absorbed, and it could also cause allergic reactions because that's your first line of defense. So there might be some immune reaction involved with this. So these are the disadvantages, and also very low amount of dose can be delivered, that's lower than 10 mg per ml, and also high molecular weight more than molecules or antibiotics or your drugs having molecular weight more than 1000 Dalton cannot be delivered through this, because as I said, there is this lipid mortar like a brick like structure there, so you have gaps in these layers through which the drug will then permeate through the skin. So if your drug is of a very big size, it won't be able to pass through this layer, so as a result it won't be absorbed. It won't be absorbed. So these are the major drawbacks of transdermal drug delivery route. First, only small doses can be administered, and drugs with higher molecular weight cannot be given through this route. Is this clear? Okay, if there are no doubts, I'll move on towards the next question. Next is, which one statement is false for bioadhesives? So we briefly discussed what bioadhesives are, and we have to choose the false statement about it. So please let me know if you know the answer. Anybody knows the answer? Somebody is saying first option. Okay, thank you for answering. Anybody else? We have to choose the false statement. Okay, let's look at the answer. The correct answer is chemically bonded bioadhesives are most highly recommended. So as I was talking about these bioadhesives, so these are actually designed to slow formulation transit time, right? So let's look at this picture first of all. So let's say you have this mucus layer, so it will have its own polymers. The polymers that are present in the mucus layer, so they have these chains coming out of that layer. So if you want to slow down the you don't want the drug to pass through this gut layer very quickly, so in that case what you can do, let's say the spear is your drug, you attach polymer chains to it, and whenever it's passing through this particular layer, the polymer chains from the drug will interact with the polymer chains in the mucus, and they'll just get entangled, and they'll just hold the drug in the place. So what will this do? This will reduce the transit, this will increase the transit time. So your drug will spend more time in the gut. That is what you want, so that it can have more absorption. If your drug quickly passes by, very very less amount of it will get absorbed in the gut. So we have designed bioadhesives to increase the transit time. So if you look at the questions, first of all, we have to choose the false statement about bioadhesives. The first option is designed to slow formulation transit time is actually correct. Can form bonds such as hydrogen bonding and van der Waals. That is correct. So your the way these chains interact with the chains in the mucus is through chemical bonds. They could be covalent or they could be hydrogen bonds. They can also be just physical entanglement of polymer with mucus. So second option is correct. Let's look at the fourth option. Adhesives can also depend on physical entanglement of polymer with mucus. That is what we just saw. That is one way for the bioadhesives to stick to this mucus layer. The third option, which says chemically bonded bioadhesives are most highly recommended, is false. Although people do chemical bonding of bioadhesives, chemical bonding meaning having covalent bonds. So that is possible, but we don't recommend it because that could hamper the biocompatibility. It could actually have an effect on the drug itself, because now you're changing the drug by attaching covalent bonds to it. So that could hamper the activity of this drug. So we don't know that. That's a questionable thing. So in order to not let the efficacy of the drug reduce, what we can do, we can go for hydrogen bonding or van der Waals interaction or just physical entanglement. So although chemical bonding is done, it is not very highly recommended. So if we have to choose the false statement about bioadhesives, option 3 is the correct answer. Is this clear? Okay, then if there are no doubts, I'll move on towards the next question. Next is, which one of these is an advantage for oral administration? I think we have been talking about oral administration a lot throughout this lecture, so should be fairly easy to answer. Okay, the correct answer is ease of administration. That is one of the advantages. So if you just look at the options here, unconscious patients cannot take the dose is a disadvantage. Low solubility drugs cannot be administered, again a disadvantage. Drugs with lower permeability cannot be administered, disadvantage. Your drugs can get degraded by the enzymes or the flora that are present in the mucus layer, so again a disadvantage. Food interactions could happen, and also it leads to first pass metabolism. All of these are disadvantages of oral administration. The only advantage is it's easier to administer this drug to the patient. They can self administer it. So these are that's all I have for you for today's assignment. If there are no doubts in this, or if you want me to repeat any of these questions, feel free to do so. Anyways, I'll be uploading this material as well as the video on YouTube, so you can go through it later on also. If there are no doubts, then we can meet next Tuesday with the week 8 lectures and some questions at 6 o'clock. Is that okay? I guess that's all for today's session then. If there are no doubts, I'll log off from the meeting. Is that okay? There are no more comments. Okay, then I'll see you people next Tuesday. Thank you for joining today. Thank you. Thanks. Okay, bye.